Hello students, today we are going to talk about the hypertensive disorders of pregnancy. Okay, so here there have been a lot of changes which have been taking place in the criteria and the terminologies of the problems related to the hypertension in case of pregnancy. So currently I'll be describing what is the latest nomenclature which has been used. Now you need to understand that if I talk about the developmental physiology in case of the changes taking place in the mother when she conceives, what happens is in the during the around 18 to 20 weeks of gestation, what happens is because of the enormous development of the placenta which is taking place, there is sudden diversion of the blood to the low systemic vascular resistance which is in the placenta, and as a result of which there is a fall in the diastolic BP which takes place normally in the pregnancy. Okay, but if there are some etiological factors, like is there some kind of problem with the placenta, abnormal placentation, or any kind of inflammatory process which is going on in the maternal body, or some kind of pre-existing kind of the pathology, then all these will predispose to the increased BP rather than the normal fall in the BP which is taking place inside the pregnancy. Okay, so in this chapter I will be talking about all the hypertensive issues which are seen in case of pregnancy. So if you divide the what are going to be the classification in the normal pregnancy, what happens is that you can divide into some which is going to be a benign kind of a condition which is called as the gestational hypertension. Okay, second is the preeclampsia and eclampsia. So if there is BP is raised, along with that there is worsening or there is production of the end organ damage, it is going to be called as the preeclampsia. Okay, in case of gestational hypertension, it is more of a benign, that is just the rise in the BP is seen, but there is a possibility that the damage can take place. So you just have to detect or pick up that is the organ damaging or not, but there are very few chances that the damage can take place. Next you have is the chronic hypertension, that is the patient is going to be having the pre-existing blood pressure raised. Okay, so before she is conceiving in the pregnancy or before 20 weeks of gestation, if she already has the raised blood pressure, what happens is it is going to be called as already existing hypertension, which is the chronic hypertension, and it can be primary or secondary. And lastly you have the preeclampsia changes which is superimposed in the case of the chronic hypertension, which means what? So in case of a patient who is already having the chronic hypertension, there are changes of the preeclampsia which is taking place. Now you need to understand what is this preeclampsia and what is gestational hypertension. So previously there was a term which was called as the pregnancy induced hypertension, which has been now not used. Okay, it is not in the current classification. Here gestation hypertension refers to when split the term. So first is means the gestation, so during pregnancy there is rise in the BP. So here it is more of a benign condition where only the rise in BP along with pregnancy is noted. Okay, rest all other features are not there. Whereas in case of the preeclampsia, what happens is there is it is a condition where along with the rise in the blood pressure inside the body, the other organs, there is increased inflammatory state. Okay, increased inflammatory state which is going to cause to lead to the other symptoms and end organ damage which is going to go and damage the kidneys, it can damage liver, it can damage eye, it can damage brain. If the brain damage occurs, it can even predispose to the condition called as eclampsia, where you see the patient having convulsions along with the raised BP. Okay, so it is one of the emergency conditions of the pregnancy. So if all these things are I'll be describing in each section. So next we proceed to the gestational hypertension. So what do you mean by gestational hypertension? As I again mentioned, it is just the increase in the BP which is taking place in the pregnancy. Okay, normally what happens is around 18 to 20 weeks, there was a fall in the diastolic blood pressure which takes place. This dip does not occur. Instead of that, the diastolic blood pressure as well as the systolic blood pressure is going to increase. Okay, so here what you see is new detection of the hypertension which is occurring after 20 weeks of gestation. Okay, so once if you consider the timeline in her antenatal profile or antenatal care, when the patient was coming to your OPD, what happens is she was having normal BP during her first visit, second visit, third visit. whenever she after she came after 20 weeks, what you found was that okay, her BP was raised. Okay, so her BP was raised, it was raised to more than 140, and the diastolic was also raised to more than 90. Okay, so what you did, you asked her to sit down for at least 4 hours, or you can also ask her to sit for some time. And if you are repeating this blood pressure measurement after 4 hours, again you found the same reading. Okay, so on two readings, if you are finding that the blood pressure is going to be raised of more than 140 systolic, or diastolic which is going to be raised more than 90, then it is going to be called as the gestational hypertension. Now, to define it as gestational hypertension, you need to rule out that okay, there is no other end organ damage. Okay, so here it is seen first time after, so there is the correlation with the timeline, that is it has to be noticed after 20 weeks of gestation. It can even be noticed during the labor or first 24 hours postpartum. Okay, then you ask her to rule out the end organ damage, you ask her various conditions. Okay, so just go for the urine RM or urine dipstick examination, where there is no evidence of proteinuria. Okay, so you would not be finding any kind of proteinuria in such patient. Apart from that, the other organs, that is you send for the patient for the other investigations, then you the liver function test, renal function test, as well as the peripheral smear, which includes the CBC, the hemoglobin level, and the platelet count. All these are going to be absolutely normal, and she does not have any signs and symptoms of the preeclampsia. Okay, so here, once the pregnancy patient is going to deliver, what happens is she is going to have return of the blood pressure to normal after at least after 3 months of the postpartum period. Okay, so these are the criteria that if a patient has been found to be hypertensive, in terms of the timeline, in terms of the end organ damage, in terms of proteinuria, which is going to be totally absent, and there would be, it is going to resolve back to the normal condition, then you can label her as the patient having gestational hypertension, which is having a new onset. Okay, now amongst gestational hypertension, you can divide the condition. Okay, so say this, since it is going to be a more of a benign condition, you have varieties. Okay, so there are only two varieties: either it is going to be mild, or either it is going to be severe. There is no moderate which is existing. So previously there was moderate, but that has been removed from the classification. We have only mild or the severe. So if the blood pressure, if the systolic is going to be more than 140, and and it should be less than 160. Okay, so it is going to be more than equal to 140, or it is going to be less than 160. That is, it is going to be maximum limit, upper limit is going to be 159. Then you can consider as mild, as well as in case of the diastolic blood pressure, if the BP is more than 90 to 109 mmHg. Okay, it is going to be called as the diastolic blood pressure of this range is going to be considered into the mild variety of the hypertension. That is going to be mild gestational hypertension. So this is going to be a relatively more benign condition. Now there is another term which is going to be called as the severe hypertension, wherein if the systolic pressure is going to be raised more than 160, or diastolic pressure is going to be raised more than 110 mmHg. So in this condition, what happens is that the prognosis, because of such high blood pressure, there the prognosis is as such going to be worsened because of the increased blood pressure. Despite you do not see any evidence of proteinuria, you do not see any evidence of the end organ damage, but the risk which is associated with such high blood pressures in case of pregnancy is going to be similar to that seen in case of preeclampsia. Therefore, manage this severe gestational hypertension is not going to be a benign condition, and management is very much similar to that of the preeclampsia. Okay, so you need to understand these two terminologies. So that was about the BP range, which I already mentioned in the previous slide. Now, if you consider what are the problems which are seen. So if the blood pressure is going to be more than 150 by 100 mmHg, and the gestational age is less than 30 weeks of gestation, or you see any kind of the end organ damage which is going to be taking, either the liver is going to get involved, or there is kidney which is going to get involved, or in the fetus also, what you see is surrounding the fetus, Because of such high hypertension, what you see, the decreased amount of the liquor MNE, which is leading to the oligohydramnios, or there would be either fetal growth restriction which is taking place, or abnormal and uterine artery Doppler. So what it all these are the complications when the blood pressure is going to be more than 160, or diastolic is going to be more than 110 mmHg. Okay, so this is more so with the case of BP if it is going to be more than 150 by 100. But if the BP is more than 160 by 110, that is severe gestational hypertension, then all these organs are going to be affected. And also what you need to understand is that if the gestational age is lesser, more chances of the worsening of such condition. Okay, so therefore, which implies what, that if the gestational hypertension has been detected in the early period of gestation, the mother is at risk of developing more complications compared to her getting detected as hypertensive in the late pregnancy. Okay, now you have how are you going to manage a patient who is having gestational hypertension but no risk factors? So what do you mean by this? So this is patient is detected with case of the hypertension, that is gestational hypertension is there. You go for examining her and you are not finding any kind of proteinuria, and all her liver function test as well as renal function test, everything is within normal limits. Okay, so there is no risk factor which is associated. Also, her BP is going to be in the range of the mild gestational hypertension. Okay. So you have to explain her the condition. So first thing is you have to take the consent. Okay. So consent is to be taken in such a case. Okay. You have to go for both the written as well as the explained consent, and you need to explain what all are the prognosis with such condition, as well as what can happen if she is actually going to continue with the pregnancy. So, and what are the risk factors which are associated. So once that is done, once you're going to explain the patient that what are the consequences and explain, and she is ready, okay, that she wants to go for further continuation of pregnancy. So you as as an obstetrician, you need to take care that there are possibilities that the patient can go into worsening of such condition. So your role is going to be detecting and picking up any kind of the progression of any end organ damage. Okay, so just need to go for detection and progression to the severe form. If at all, just pick it up. Okay, apart from that, you have to go for monitoring of the vitals as well as urine. So go for the ask the patient to go for the blood pressure monitoring, and she can, since it is going to be a mild case without the risk factors, she can go for monitoring her blood pressure at home as well. Okay, apart from that, you have to go for the quantitative dipstick urine test. Okay, so if it is going to be more than +1, then ask her to come to the hospital immediately for further management. Ask her to go for daily fetal movement count, that is at least she should have daily fetal movement count more than 10. If she is experiencing decreased fetal movement, then she has to visit the hospital. You have to tell her that she can consume any amount of the diet, and any amount of the salt restriction is not advised, because it is not going to be helpful in case of the preeclampsia. Then you have to tell her to avoid the strenuous exercise and go forth with all these. So ask her that in a paper she has to write her daily BP as well as the DFMC, and visit the clinic every weekly. Okay, so weekly visits of the clinic needs to be done. Whenever she is going to attend the clinic, as an obstetrician, you are going to go for reporting of all the end organ damage tests. Along with that, you go for looking in the urine whether there is absence or presence of the proteinuria or not, and ask her for the signs of the severe imminent eclampsia, like is there patient is experiencing the headache, or is there any kind of blurring of vision, or there is any kind of vomiting, or there is going to be epigastric pain or liver pain. Okay, so all these signs to be asked, or if she had any kind of complaint of the convulsion. Okay, for fetal assessment, you are going to go for the daily fetal movement count that assessed, as well as the uterine fundal height. This will help in two ways. It can even detect the fetal growth restriction. Okay, So at diagnosis, so once a patient is going to get diagnosed that okay, she is going to have gestational hypertension, you are going to go for assessment of the fetal condition. Just go for assessing the growth. First of all, you need to assess the growth, where you are going to go for the biparietal diameter. You are going to assess the head circumference, the femoral length, as well as the abdominal circumference. Okay, once that is done, surrounding the fetus, you need to assess the level of the liquor. Okay, so liquor level is going to get assessed, and then you go for the umbilical artery Doppler. Okay, so mind well, it is going to be umbilical artery and not uterine artery. Umbilical artery is one of the screening tools for the fetal, not screening tools, monitoring tools for the case of the fetal growth restriction. Okay, so that is going to be done. So this growth scan has to be done every 3 to 4 weekly. Okay, so to pick up that, okay, is there any kind of lag in the growth taking place or not? For amniotic fluid, you have to go at least once a week. Okay, so you can manage such a patient of the gestational hypertension who is having mild hypertension with no symptoms of proteinuria or any end organ damage. Okay, now that is going to be the expectant management. Now if you're going to go for the expectant management, meanwhile you're finding that okay, the patient is developing worsening of such condition, either she is developing proteinuria, which means she is getting converted into the preeclampsia. Okay, or the BP is getting elevated, that is, it is going to convert into the severe gestational hypertension, or the fetus is getting compromised by like the decreased fetal movement, or you have the fetal growth restriction or decrease in the growth velocity and development, then you require further evaluation. You just need to admit her and you need to further evaluate such a condition and decide that okay, she is requiring delivery or not. Okay, so if the patient is having normal things, okay, then there is no complication or nothing. Just go for every week assessment of this condition, and then if the mother is going to be safe, the baby is going to be safe, then you can go for the stretching of the pregnancy till 38 weeks of gestation, and you can continue such mild gestation hypertension up to 30 to 39 weeks and deliver planned delivery after that. If the cervix is going to be in bit ripe at the time of the 39 weeks of gestation, then you can go for the vaginal delivery by stripping and other augmentation method. If it is not there, you have to go for the ripening of the cervix with the cerviprium gel and that is PGE2 gel, and then you can go for induction of labor with oxytocin or misoprostol. Okay, so that was all about the mild gestational hypertension. So I will be again shortly telling you what actually it means. So on first detection, you are detecting a patient with the raised BP. You go for admitting her. You go for initial assessment, where you are going to initially evaluate and rule out all the possibilities of the complicated conditions like the severe BP raised, or there is the end organ damage, that is either the preeclampsia. So you just rule out every other complications, as well as you assess the fetus. Okay, so this is going to be the first step of the initial assessment. Okay, so this is at nx number of the gestation age. Now if everything is going to be right on this initial set of assessment, what you need to do is call her for the weekly follow-up, as well as you have to tell her for the home monitoring of the BP. Okay, once this weekly follow-up is normal, you can go for again re-evaluating every week. Okay, as well as the growth scan of the fetus is to be done 3 to 4 weeks, as well as NST and the Leica status is to be assessed weekly. So if all these is normal, you can safely tell her, okay, you can continue the pregnancy up till 39 weeks and then deliver 30 to 39 weeks and then deliver at that particular time. Okay, if it is not going to be appropriate, then just go for the termination. Okay, meanwhile, if the BP is raised more than 140 by 90, then you may require antihypertensive if the blood pressure is going to be more than 150/100, and based on various criteria I'll be describing in that later, you can give the antihypertensive medications which are safe in the pregnancy. Okay. Now, if a patient comes to you with the gestational hypertension, which is going to be a severe form, okay, so severe form, or there are presence of the risk factors. Okay, so what do you mean by that? So severe form means what? It is going to be BP which is systolic, which is going to be more than 160, as well as more than 110 diastolic BP. Okay, so if it is going to be this kind of condition, you have to become very alert and vigilant, because it is going to be a severe form of the gestation hypertension, and the risk of complication to mother in such condition is as equivalent to that of the severe preeclampsia. Okay, so it is a serious condition. Now, whenever you are managing such a patient, what happens is you have to keep three things in your mind. That okay, the BP should be controlled, number one. Second is that you have to, if at all the patient has getting converted into preeclampsia, you have to detect it early, and you have to prevent the end organ damage which is taking place, and there should be good perinatal outcome. Okay, so to the fetus, as well as prevent the detect any kind of fetal decompensation which is taking place, as well as detect the end organ damage or injury in the mother, detect preeclampsia, and control the blood pressure. So again, in this condition, the initial evaluation is going to be same. That is, you admit the patient. So first difference here is you always have to go for the admission of such kind of a patient. Okay, so if a BP is found to be in a high range, admit the patient. Once that is done, you have to initially assess the patient and evaluate her in terms of everything, in her own status as well as the fetal status. So when it comes to her own status, what you are going to go is that we know that because of such raised BP, there might be affection to the hematological conditions. So you have to detect any kind of the decreased platelet count or decreased hemoglobin level is developing, or hemo concentration is developing in case of CBC. Then you have to check the level of the liver function test, as well as the which includes the SGPT as well as SGOT and the LDH. Now, LDH would be elevated because of the lysis of the RBC. Okay, SGPT might be raised. So if it is more than 2 times the normal, just 2 times the normal, that is in the range of 70 or 72, then it is abnormal. Or if the urea is going to be altered, or creatinine which is going to be increased to more than 1.1. So here note these values are different from that of the non-pregnant state. Okay, so wherein this much level, the creatinine upper margin is going to be only 1.15, but here the upper limit is going of the creatinine is going to be lower down to the 1.1. Okay, so once that initial evaluation of these the blood tests of the mother is done, you have to go for assessing the fetus. Okay, so the for fetus you have to go for every weekly cardio topography test. Okay, apart from that, the growth scan is to be done, assess the level of the liquor which is around the fetus, as well as you have to go for checking the level of the umbilical artery Doppler velocimetry every 2 times in a week. Okay, and you have to go for regular monitoring of the blood pressure. Okay, if at all anytime if the blood pressure is going to be more than 150 by 100 mmHg, you have to become alert. If everything is normal, in such cases you have to repeat the weekly investigations in such a mother. Okay, now if I talk about when to start the antihypertensive agents, the according to ACOG, if the blood pressure, that is systolic blood pressure, is going to be more than 160, or if the diastolic pressure is going to be more than 90, then and then only the antihypertensive agents are required. Okay, but according to NICE criteria, what it states that if the systolic blood pressure is going to be more than 150 and diastolic pressure is going to be more than 90 by 100, that was according to the older guidelines, but the newer guidelines states that even if the BP is going to be more than 140 by 90, you can start the antihypertensive agents, with the target being the systolic should be at least less than 135 mmHg and the diastolic should be less than 85 mmHg. Okay, so which are the antihypertensives you are going to start in such a patient? So we begin with those antihypertensives which are going to be safe in case of pregnancy, such as the labetalol is going to be the first line of management. Second is going to be nifedipine, and lastly, if not available, you can go for the methyl dopa. Okay, all the antihypertensive agents which are used in a non-pregnant state, like the angiotensin receptors blockers as well as the ACE inhibitors. So all these are to be actually stopped. They are not to be used in pregnancies because they can cause the teratogenic effect as well as fetal growth restriction in case of the pregnant female. Okay. So this was about the first initial evaluation which I'm going to do. Along with that, you go for BP monitoring and control the BP into this particular range where the target BP is going to be 135 by 85 mmHg. Okay. Now, depending upon the age, gestational age of the mother, as well as depending upon the gestational age of the fetus, as well as the condition of the mother, you can either go for the immediate termination or you can continue the expectant management with the surveillance to the fetus as well as to the mother. Okay, so here, if the BP is going to get controlled, then that is the first most indication that okay, you can go for the BP is in under control, you can go for expectant management. Apart from that, the gestational age should be less than 37 weeks of gestation for the for if you're planning for undergoing the expectant management. Okay, if the gestational age is going to be more than 37 weeks of gestation, then you need to go for, do not think further, just if the cervix is going to be favorable, you can go for the vaginal delivery, which is actually a safer option. Okay, so vaginal delivery, except if there is severe kind of the fetal growth restriction or the mother is at severe risk or there are any obstetric conditions indications for the cesarean section, then and only you need to go for cesarean section. Otherwise, if the mother has crossed, if the fetal gestational age is going to be more than 37 weeks of gestation and the mother is diagnosed with the features of severe preeclampsia, you have to go for termination of the pregnancy where the vaginal delivery is going to be the preferred mode. Okay, now there's a female who is coming to you at 35 weeks of gestation. She is diagnosed with a severe blood pressure. Okay, and you go for examining her, you're not finding. So here the case is going to be that let's consider a female with the raised BP. Okay, her period of gestation is going to be 35 weeks of gestation, and whenever she's coming to you, you went for all the initial assessment with the and those are absolutely normal. Then you gave her antihypertensive and the blood pressure was controlled. Then what you can go for is her explain her that this is your condition and offer her the expectant management. Okay, so here expectant management is to be offered to such a patient. But the second scenario is that whenever she came to you, the blood pressure was raised and initially proteinuria was not present. So you labeled it as the case of the severe gestational hypertension. You gave her antihypertensive agents. So to begin with, you gave either labetalol or then if it was not available, you gave nifedipine or methyl-dopa. Despite that, the blood pressure was not controlled. Then and there are certain conditions where you are not going to offer her the expected management. Rather, go for immediate termination of the pregnancy. So what are these conditions where you're going to go for the immediate termination? So this is the condition. One of them is the BP cannot be controlled despite the antihypertensive agents. Okay, that is going to be your first condition. Apart from that, we all know that such kind of high blood pressure is going to go and cause damage to the CNS, cardiovascular system, liver, as well as the renal function test is going to be altered because of the damage to kidney. So any kind of such conditions is showing, which is called as the end organ damage. If it is seen, then you go for termination, or there is development of the fetal compromise which is taking place. That is like, is there any kind of the arrest of the fetal growth, that is the fetal growth restriction takes place and no more further growth, arrest takes place, or the umbilical artery diastolic flow is going to be absent, or there is reversal of the flow to the umbilical artery. Actually, so this umbilical artery is responsible for the transport of blood to the fetus. If the during diastole, if there is reversal of flow, which means there is stoppage of the flow to the fetus, or there is abnormal fetal monitoring, or lastly, if there is rupture of some kind of the subplacental vessel leading to the abruption, all these conditions, you are not going to further stretch the pregnancy. Just go for termination irrespective of the period of gestation. Okay, so that is one of the clause. Now, if all these are in such cases, if the cervix is ripe, just go for vaginal delivery. If cervix is unripe, you can go for induction after control of blood pressure. Okay, and in case of the post delivery, you just need to control the blood pressure as well as avoid methargin. Now the other condition is that if the period of gestation is going to be less than, if the period is less than 37 weeks of gestation, okay, and all these things are not there, that is all these the clause which was stating that there are no indication for termination of pregnancy. What you need to go for is that you can go for, if the period is going to be more than 34 weeks of gestation and less than 37 weeks of gestation, you go for initial assessment, wherein you are going to have the baseline values. Okay, then go for weekly tests. Okay, so 1, 2, 3, 4. Then go for the weekly or bi-weekly tests, which includes the assessing the level of the CBC, the renal function test, the creatinine value. Then you have SGPT, SGOT, level of the LDH. You go for the BP monitoring daily. Okay, you go for urine. You go for dipstick test. Analysis for assessing the level of the proteinuria. Okay, which means what? If this is occurring, which means there is the conversion of this severe preeclampsia, severe gestational hypertension into preeclampsia. Okay, or weight gain, that is daily weight monitoring. Okay, apart from that, fundal height is taken, and edema. Daily ask her for the signs of the severe imminent preeclampsia, like the headache, blurring of vision, vomiting, or the epigastric pain. So all these severe signs of the preeclampsia needs to be asked on. Okay, apart from that, you have to go for the fetal monitoring. So this is a kind of this the management where the patient is having severe gestation hypertension, that is BP, which is going to be 160 or 110 mmHg diastolic, with absence of the proteinuria, and on initial test everything was normal, and you plan for going for expectant management. Okay, so in that condition, these are the components of the expectant management you need to be doing. Okay, fetal movement, that is the DFMC. You have to go for the Doppler of the fetus, which is done every twice weekly. You have to go for non-stress test, which is also done twice weekly, and amniotic fluid assessment. Okay, amniotic fluid index is to be assessed, and you can go for the growth scan. So all these needs to be done. Now, if at all any time these are going to be normal, you can continue the pregnancy up till the end of the 37 weeks with such kind of the monitoring. Okay, once that is done, along with that, you have to give the antihypertensive agents to the patient, okay, for controlling the BP. If at all, anytime you can, during the expectant management, you are finding that, okay, there are these kind of the signs which are developing, that is either the BP is not able to control, or the fetus is getting worsened, or the maternal damage is going to take place, then just go for straight away termination. If everything is normal, then you can continue the pregnancy till 37 weeks of gestation and plan the termination. Okay, for termination, depending upon the status of the cervix, you can go for the vaginal delivery or induction, and the cesarean section is only done if there is severe compromise to the fetus, or fetal distress develops, or if there is actual obstetric indication for cesarean section. Otherwise, this vaginal delivery is the preferred mode of delivery. Post delivery, you have to be very vigilant. Why? Because you have to go for monitoring of the BP, as well as you have to avoid the methergin. And if any kind of the complication which develops, then like what you can see is the postpartum hemorrhage that has to be vigilantly observed. Apart from that, there is risk of development of the pulmonary edema in such cases, and you can give, if the BP is not controlled, you can give injection furosemide. Okay, So this can be given post delivery. So that was all about the gestational hypertension, where we had two categories. One was the mild gestational hypertension and the second one was the severe gestational hypertension. And in case both these cases, in case of the mild gestational hypertension, when no end organ damage is noted or no proteinuria is noted, you can go for continuation and weekly monitoring of the patient till 38 to 39 weeks of gestation and terminate later. Whereas in case of the severe preeclampsia, you have to terminate, not continue pregnancy more than 37 weeks of gestation, and between 34 to 37 weeks of gestation, you can go for the weekly assessment. One more important thing I forgot to mention here is that if the duration is going to be less than 34 weeks of gestation, then you have to give the betnazole, okay, for the fetal lung maturation. So that was one important point I forgot to mention here. Now next we move on to is the preeclampsia. Okay, so how is this different from the from the gestation hypertension? So apart from just raised blood pressure, patient might also have one of the following: either there is proteinuria or there is signs of the end organ damage. Okay, if there is BP is going to be raised, but you do not find proteinuria, but there are signs of the end organ damage, it is going to be called as the atypical preeclampsia. Okay, and if there are, what are the signs or what are the possibilities of the end organ damage? So either the CNS is damaged or there is the blurring of the vision. Okay, if you move down in case of the female, so let's consider this. So there is basically either patient is going to have a headache, okay, or blurring of the vision, okay, or she is going to have her heart is going to get affected. So there is basically development of the query myocardial infarction or pulmonary edema. Okay, so pulmonary edema develops, or there is abnormal liver function test. So liver function test is abnormal, or there is development of the HELP syndrome. Okay, so there is development of the HELP syndrome, wherein either what you see is either there is hemolysis or the elevated liver enzymes or the low platelet, or there is the subcapsular hematoma which is taking place in the liver, or in case of the renal failure, what you see is the raised creatinine, okay, or there would be the fetal growth restriction. So all these conditions would be included as the signs of the end organ damage. Okay, so that is about the preeclampsia. Now we have two varieties in the preeclampsia. So if you talk about the classification of grades, you have mild preeclampsia and you have the severe preeclampsia. Okay, so in case of mild preeclampsia, what you have here is the raised BP plus the proteinuria, which is going to be in the grade +1. Okay, whereas in case of the severe preeclampsia, you have the BP which is going to be raised. Along with that, there are signs of the end organ damage, plus you have the proteinuria, which is going to be grade 2 or more than 2 grams of of per 24 hours of the protein excretion. The BP in case of mild eclampsia would be in the range of 140 by 160 mmHg systolic, or diastolic would be more than 90 by 110 mmHg, whereas in case of severe preeclampsia, you have more than 160 systolic BP and you have diastolic blood pressure of more than 110 mmHg. Okay, so that was about the varieties of the preeclampsia. Next, we move on to what are the risk factors why preeclampsia can occur. So here, if the patient has past history of preeclampsia, which is forming one of the major risk factor, in case of the primi gravida, this is a very important study which has been noted that the primi gravida are going to be at risk of development of the preeclampsia. Increase in the weight, which is going to be BMI more than 30 kg per meter square, or if there is pre-existing renal disease, or if there is pre-existing pre-existing any kind of the autoimmune condition in the mother, or there is even history of the systemic lupus erythematosus, all these is going to predispose to development of the preeclampsia. Then you need to remember that any kind of the condition which is going to have the big placenta, okay, such as in the case of the immunization, or if there is twin pregnancy, or if there is diabetes mellitus, okay, or even if there is molar pregnancy. So there is all these conditions with the large placenta, or even if big baby, all these are at risk of development of the preeclampsia. So these are the conditions with the big baby. Apart from that, apply is going to be at the risk factor. So that was all about the risk factors which are associated. Now we talk about the pathophysiology. So what exactly is causing the development of preeclampsia? So there are various large number of hypotheses which have been proven. Amongst them, first is the abnormal placentation. So as I mentioned in the risk factor, there is abnormality of the placenta. So which means what, any kind of abnormality in the placenta which is taking place may predispose to development of the preeclampsia. So if you talk about abnormal placentation, what happens is, during the normal pregnancy, what happens is there is trophoblastic invasion. So you can see in this picture. So as you can see this picture, this is going to be the cytotrophoblasts which are present, okay? So they have this capacity that they go and start invading the maternal blood vessels, and this invasion takes place in the spiral arterioles at the first stage, which is going to be 12 weeks to 14 weeks of gestation. This takes place only up to the decidua, okay? Later on, at around 16 to 18 weeks of gestation, further invasion of these cytotrophoblastic takes place, and these cytotrophoblasts are going to get converted into the endovascular cytotrophoblast, where they go and cause what? They go and cause the destruction of the normal myometrial tissue. Sorry, 1, 2, 3, 4. They go and cause the destruction of the normal endovascular tissue, okay? So the inner lining is going to get replaced with these cytotrophoblasts, and they are now called as the endovascular cytotrophoblasts. Okay, so as you can see in this picture, there is the endovascular cytotrophoblast. So because of this is something which is taking place normally. What happens is, because of this kind of the such replacement, what happens is spiral arterioles which were actually muscular, okay? So initially the spiral arterioles which were muscular and responsive to the pressor agents, okay, plus responsive to the pressor agents, this becomes, now that muscular agent is actually replaced by the endovascular cytotrophoblast, and these arteries are no longer be able to respond to such kind of the pressor agents, and they become into the large channels. Okay, as you can see, there is this large channels which are getting converted, okay? So whole large channels, high flow, low resistance. Ultimately, they become a capacitance vessels. Okay, so there occurs, these vessels would become large pipe-like channels where they have very minimal resistance, and the large amount of the flow and blood volume is going through these channels, ultimately to supply to the blood to the placenta. So that is a normal change which is taking place. Now what happens is, instead of these cytotrophoblasts going and getting invaded into such kind of the thing, these spiral arterioles would not be getting invaded. Ultimately, the cytotrophoblasts stay here only up to the decidual tissue. So these spiral arterioles keep on having their own tortuosity as well as muscular component, which is going to be responsible to the which is going to go and react to the pressor agents. So this is the main pathology behind the in case of the placenta previa. So that is the first stage. Now, in case of abnormal placentation, there has been a two-stage hypothesis which has been presumed. Okay, so first stage of which is going to be abnormal placentation. Now, because of such kind of these responsive arteries to the pressure agent, what happens is that the blood flow to the placenta is going to be compromised. So ultimately, via these channels, the blood is going to go and reach the placenta, that is going to be compromised, because of which what happens is it leads to the hypoxia. Okay, and in response to such hypoxia, there are large number of the inflammatory mediators which are getting released from the placenta. Okay, so there is release of the inflammatory mediators. Okay, so in the first step we have the development of the abnormal placentation, and in the second stage we have what? So second stage we have the release of the inflammatory mediators from placenta. These inflammatory mediators, and they go into the system. Okay, so they, from the placenta, they are going to get released into the maternal blood and go into the systemic circulation, and into different organs. They are going to cause the various effects. Okay, of which one is the increased capillary permeability. Okay, they are going to cause the damage to the endothelium. Okay, ultimately it leads to the damage to the increased capillary permeability. This leads to the hemo concentration plus increase in the viscosity of the blood, and the fluid is lost into the third space. Okay, this explains why edema is also seen in such patients. Apart from that, the damage to the endothelium, it is going to cause the, in the kidney, it goes and affects and causes the proteinuria. So ultimately the effect is the second stage, which is the release of the inflammatory mediators because of hypoxia, which is occurring inside the placenta, and ultimately you have large number of effect which is seen. So it is a disorder of placenta is getting converted into a whole of the systemic disease. So that is the main pathology of the preeclampsia, which is very different from that seen in the case of the normal hypertensive woman. Okay, so that was about the two-stage hypothesis. Okay, so it was about the two-stage hypothesis. Next you have is the genetic imprinting. So what does this genetic imprinting state? That the development of preeclampsia is not just associated with the single gene, but it is going to be a multifactorial condition, and wherein what happens is there is a genetic conflict theory wherein it states that the genes of the fetus as well as the mother, they are going to interact in such a way that the ultimate goal is to develop more amount of the blood supply to the fetus, but there is some kind of issue which is taking place amongst these genes which leads to the development of the preeclampsia. So in case of the genetic imprinting, that means there is the mothers of these babies are going to have the history of the preeclampsia. So that was about the genetic imprinting. Now again, this is a picture showing what I explained you was the two-stage hypothesis, wherein because of any factors, like either it could be a genetic factor, it could be environmental factor, immunological condition, or a metabolic condition, all these are going to predispose to the abnormal trophoblastic invasion. As you can see in this condition, a normal pregnancy has these abnormal, have the cytotrophoblast into these channels as well, but these are not in the case of the preeclamptic woman. Okay, so ultimately what you see is the development of the placental ischemia and the hypoxia, leading to some kind of the angiogenic factor imbalance with the increased inflammatory condition, ultimately producing the endothelial dysfunction at various organs. So if it is in this brain, it is going to produce the increased permeability of the vessels in the brain, leading to the cerebral edema. It can also cause the activation of the coagulation system, leading to the DIC, as well as damage the red blood cells, leading to the hemolysis. It can even lead to the hepatic necrosis and ischemia. And lastly, most importantly, what you see is the proteinuria, edema, as well as the hypertension because of the affection of the kidney. The other factors associated in the pathophysiology of the preeclampsia is that there is alteration in the ratio of the prostacyclin as well as thromboxane A2. That is, abnormal prostacyclin to thromboxane ratio takes place, and increase in the vasopressor response ultimately takes place. Okay. Also, normally in pregnancy, there is refractoriness to the angiotensin 2 which is occurring, but this is not seen in the case of the preeclampsia. Most importantly, you have, in response to the hypoxia, there is this tyrosine soluble FMS like tyrosine kinase 1 which is getting released. But what happens is this this soluble FMS like tyrosine kinase is going to go and cause the blockade of the vascular endothelial growth factor as well as the placental growth factor receptors, and ultimately the vessels cannot grow. So this is going to cause the endothelial dysfunction. So that is about these factors. You have an immunological response which is seen here. What happens is this states what, that if there is past exposure to the paternal antigens, then there are less chances that the mother is going to develop preeclampsia. On the contrary, which is seen in the case of the primigravidas, which are at a high risk of developing the preeclampsia. So here, inadequate maternal antibody response is produced to the fetal allograft material, and it causes, this antibody response is going to cause the vascular damage. Okay. So at the end, again, I would like to repeat that placenta is going to be the main culprit, wherein termination of pregnancy is going to be the main target. So if you talk about the different organs which are getting affected, so if first we talk about the changes in the kidney. So here what happens is, because of the decrease in the intravascular volume, because of the damage to the fluid which is getting lost into the third space, what happens is the renal blood flow is also going to decrease, as well as the glomerular filtration rate is also going to decrease. Okay. The main reason is that total blood volume is going to get decreased. Okay. Ultimately, this is going to get translated, and it is going to cause the increase in the serum creatinine as well as the urea. Also, if you go for histopathology, what you see is the glomerular endotheliosis, that is, the endothelial lining is going to undergo proliferation. Okay. And apart from that, preeclampsia stands as the first cause, wherein you see what is the most important cause for the acute renal failure which is seen in obstetrics is preeclampsia. Okay. And main reason is the tubular necrosis. Okay. Sometimes cortical necrosis can take place, but most importantly, what is seen with preeclampsia is the tubular necrosis. Then in the brain as well as in the vision, there are a lot of changes which are taking place. So first is patient, if you talk about eyes which are getting affected, the most common complaint is the blurring of vision or the scotoma. Okay. And why does this blindness occur? So it is mainly because of the vasospasm which is taking place in the occipital lobe of the brain. Okay. And rarely it can even be because of the affection at the retinal level. So if it is because of the occiput, it is going to be called as the amaurosis, and this is mainly because of the edema inside the occiput. Whereas sometimes what happens is inside the retina also, you all know, so in case of this is the eye and this is going to be the brain, wherein occiput lobe is there. So either there is amaurosis which is because of the cerebral edema, or there is development of the retinal hemorrhages which are taking place in the retina, or retinal ischemia. If retina is going to get affected, it is going to be called as the Pasteur's retinopathy. Okay. And if it is going to be retinal detachment, it can be unilateral or bilateral. If occipital is going to be getting affected, then this is going to be reversible. Okay. Because once the edema resolves inside the brain, then the vision is automatically gained. Okay. So most common ophthalmological finding, if you are going to go for the fundus examination in a patient with a preeclampsia, is increased vein to artery ratio as well as the segmental vasospasm. Okay. Now, if you talk about the cardiovascular system, you have increase in the blood pressure which is taking place, but the central venous pressure as well as the pulmonary capillary wedge pressure, they are going to more decrease further, which was initially staying constant, but here they are going to go and decrease. If you talk about the blood coagulation profile, okay, there is alteration in the blood coagulation profile ranging from the damage to the platelets to damage to the RBCs, leading to the microcytic angiopathic hemolytic anemia, as well as the blood viscosity is going to increase because the PEG cell volume is going to increase and the fluid is lost in the third space. You have hemoconcentration which is seen, and lastly you have the disseminated intravascular coagulation which is taking place. The volume hemostasis, if you consider, there is hemoconcentration. And why does this occur? Because of the increased capillary permeability, you have the generalized edema which is taking place, as well as there is proteinuria. Both are going to cause the hemoconcentration. Proteinuria is going to cause decreased oncotic pressure. Okay. Here liver is also going to get affected, and what you see is the periportal hemorrhage which is taking place. It can lead to ischemia, and these can coagulate together and form the subcapsular hemorrhage which is seen just beneath the Glisson's capsule. Okay, so if what happens is just beneath the Glisson's capsule, if the hemorrhage is taking place, what happens is this is going to cause the stretching of the Glisson's capsule, and it is one of the signs of the imminent eclampsia. The patient is going to have the epigastric pain or sudden pain in the epigastrium. So all these are actually signs of imminent eclampsia or severe worsening of the eclampsia. Apart from that, you have this, if this severity increases, it may even predispose to the rupture of these capsules, and a liver rupture can take place. Okay, so if the liver is getting affected, there might also be associated with a syndrome which is called as the HELP syndrome, wherein you have the H stands for the hemolysis, E stands for the elevated liver function test, as well as the low platelet which is associated with it. Okay, so if you talk about hemolysis, how you are going to detect it? So because of the lysis, there is raised level of the LDH which is going to be above 600 levels. Okay, or if you go looking for peripheral smear, you will see that okay, there are broken RBCs which are called as the schistocytes. Okay, or the bilirubin level which is also going to be raised, which is more than 1.2 gram per deciliter. So all these indicate the indirect evidence of the hemolysis. Okay, if you go for measuring the level of the liver function test, which is going to be the SGOT or SGPT, the values of these, that is the AST, aspartate serum transaminase, or ALP, alanine transaminase, these are going to be more than twice the normal. Normal value is going to be 35. The only twice increase is also an important thing, which is going to be more than 70 international units per liter. Okay, lastly you have the low platelet count, which is going to be less than 1.5 lakhs per cubic mm. So because this is a severely worsening condition, you can see the large number of complications which are associated with these HELP syndrome. That is, simultaneously the patient may even get predisposed to eclampsia or development of abruption, pulmonary edema, or renal failure which is taking place in this place. And if these things happen, there is increased disposition to the development of the postpartum hemorrhage. The management, so management is going to be similar to that of the severe preeclampsia. Go for immediate termination, stabilize the patient, okay, control blood pressure, okay, and you can also, for prevention of the seizures, you can give the magnesium sulfate in such patient. Okay, next you have the changes which are taking place in the brain. So this is going to be, brain is also one of the major organ which can if get affected. 1 2 3 4. Brain is also one of the major organ which, if gets affected, can lead to the development of the convulsion which is called as the eclampsia. So here what you see inside brain is either development of edema, or there is bleeding which is taking place both because of the raised blood pressure, or even the basal ganglia infarct or the cerebral infarct. Okay, so that was all about the pathology of all the organs. Now if you talk about the complications which are seen in case of the preeclampsia, So this could be either the mother is going to get affected or the fetus is going to get affected. So if the mother is coming to us in the antenatal period and she's diagnosed with the development of the preeclampsia, then there are very high chances that during antenatal period you have to explain these conditions to the mother, that during pregnancy either she can develop the increased blood pressure which affects the CNS, so it can affect lead to the eclampsia, okay, or it can affect various organs. So if it is affecting the placental hemorrhages takes place, it can cause the abruption, okay, so abruption can take place, or kidneys would be affected, okay, which could lead to the anuria or oliguria, okay, or eyes would be affected, so visual loss, so all the organs which were visual damage can take place, or even the liver can be affected, which can lead to the HELP syndrome, okay, eclampsia, or it can lead to the cerebral hemorrhage. Even lungs might be affected, which can lead to the adult respiratory distress syndrome or pulmonary edema. So you just have to visually remember this picture. If at all, there would be iatrogenic prematurity can also take place in the fetus. So prematurity. So all these are the risk factors or complications if a female is going to get diagnosed with preeclampsia in the antenatal period or the pregnancy. Now, once this woman is asked to undergo labor, what happens is there is again increased risk of the eclampsia, and once this, what happens is there would be increased chances of the operative delivery, okay, operative delivery, or even the patient can have the increased risk of the death as well as eclampsia. And lastly, once because the coagulation profile is going to be altered because of the risk of the HELP, okay, so you have the low platelets, you have development of increased risk of DIC, everything, all these can predispose to development of the postpartum bleeding and hemorrhage. And for this control of DIC, you have to give the fresh frozen plasma to the patient, okay, depending upon the level of the PT and the APTT. Now, during puerperium, what happens is again there is risk of development of eclampsia for at least first 48 hours. Patient might even undergo shock because of the postpartum hemorrhage, or there would be vasomotor collapse, increased risk of infection, and lastly you have increased risk of the death. So that was all about the complications which are seen in the mother. You have to explain these complications to the patient. With her body changes, okay, and what are the complications which take place in the fetus, you also need to explain her. Apart from that, in the patient, once the patient has been managed in future, you also need to explain that okay, there are chances that the raised BP which she had in the pregnancy can get converted into the chronic hypertension, okay. Apart from that, there is in the future pregnancy also, if she conceives, there are chances that she might also have again preeclampsia, okay, so recurrent preeclampsia as well as chronic hypertension. Two risks need to be explained. Patient may also have the chronic pyelonephritis, increased cardiovascular morbidity, as well as increased risk of the maternal mortality and ICU admission, okay. Now, if you talk about the fetus, so we know that what happens, this is the placenta. It is the main source of the supplying the blood to the fetus, from where the exchange of various nutrients takes place to the fetus, and ultimately the growth of the fetus can take place. Now, in case of the preeclampsia, this placenta is going to be a defective condition. So what happens is ultimately the growth is affected, okay. So in terms of growth, you have, if the proper blood supply to the fetal renal vessels is going to take place, what happens is fetus is going to produce normal urine, and they can have the normal amount of the liquor. So first thing would be decreased would be the liquor, which is going to get decreased. So the fetus might have the oligohydramnios, okay. Apart from that, if even if the liquor produce is going to be normal, but slowly growth is going to get affected, then it can lead to the intrauterine growth restriction, and sometimes there is asphyxia, and ultimately the fetal death can occur, which is because of the uteroplacental insufficiency. Sometimes what happens is there is development of the antepartum hemorrhage, like the abruption which develops, then all these can also lead to the sudden death of the fetus, okay. because of all these complications which are taking place, you might have to go for the premature termination of the pregnancy, and this might even lead to the iatrogenic prematurity, or there might sometimes what happens is in the case of the development of complications like abruption or or the eclampsia, there is spontaneous onset of the premature labor, and the fetus is going to be premature. Okay, so all these causes the increase in the high risk of the fetal, that is the perinatal mortality, to as high as 30% cases, which means in one third of the cases there is the risk to the fetus, mainly because of the prematurity, asphyxia, and the effects of the drugs which we are going to give it to the mother, like the magnesium sulfate. Okay, so that was about the complications which we see in the case of the preeclampsia. Now, how we are going to manage such a case? So, again, if you talk about the definition of what is preeclampsia, so basically you have the blood pressure. So, blood pressure either it is going to be 140 by 90 to 1110 by 1234. If you talk about blood pressure, either it is going to be systolic more than 140 by 159 mmHg, or diastolic between 90 to 110 mmHg, or it is going to be more in case of severe preeclampsia more than 160 by 110 mmHg. Then on the basis of proteinuria, if it is going to be more than 300 milligrams per 24 hours, or there is persistence of +1 dipstick on the qualitative test, or there is protein creatinine ratio is going to be more than 0.3. Okay, so all these are the signs that the proteinuria is going to be present. Next, you need to look for this end organ damage, that is serum creatinine, if it is going to be more than 1.1 milligram per deciliter, or thrombocytopenia, hemolysis, raised liver function tests like SGPT and SGOT more than 70 international units per liter, or the signs of severe preeclampsia, that is imminent eclampsia, or proteinuria which is worsening, which is going to be more than +2 on dipstick test, or more than 2 grams in 24 hours. So all these are the signs you need to rule out. Okay, so in case of mild preeclampsia, you only have the raised BP. Along with that, you have the proteinuria in the range of +1 or less than 300 milligrams per 24 hours. These signs would not be present in case of mild preeclampsia. Now, if you talk about the management of such a case, so the management is again going to depend upon the gestational age of the mother. Okay, if gestational age is going to cross more than 37 weeks, just go for delivery of such a patient. Okay, next is that you have to check that, okay, it is less than 37 weeks of gestational age. So, is it between 32 to 36 weeks of gestation? Then you have to go for initial assessment of such a case, wherein you, if the BP is, try to go for recording the BP. That is, here the BP should be less than 150 by 100. Also, proteinuria should be less than 1 gram platelet level. So if any of such condition is seen, that is, if the BP is increased, so raised BP, or proteinuria is increasing, or there is worsening of the platelet count, or the fetus is affected, which either development of the oligohydramnios IUGR, or the Doppler studies are abnormal, like the raised ST ratio, or the end diastolic flow is compromised, or the patient is starting complaining of all these complaints of the severe preeclampsia, like the vomiting, like blurring of vision, or epigastric pain, all these things, this can lead to the increased risk of the worsening of the patient in such condition, or if the patient has elevated liver function test, or if the patient is actually unreliable in terms of compliance. So if you consider this, if I'm drawing a picture of this patient, okay, so either she has the signs of the imminent eclampsia, like she's having headache or the blurring of vision, or she has vomiting or epigastric pain. Apart from that, you go for the liver function test, you go for the renal function test, and then in the fetus, you see the amount of the liquor, you see the growth of the fetus, and you see the Doppler. So any of these parameters are altered, okay, then straight away what you need to do is you need to again admit the patient, and you can go for the reassessing it in the detail. Okay, if all these conditions are not present, you can continue the pregnancy with the weekly monitoring and terminate at 37 weeks completed of gestation. Okay, but if all these parameters are abnormal, again admit the patient. Similarly, if the gestational age is going to be less than 32 weeks, you go for initial assessment and admit the patient. Once that is done, you go for continuous assessment. You go for daily monitoring of the blood pressure in this patient. You go for weight monitoring of this patient. You go for input output monitoring of the urine, as well as you go for the urine dipstick test for the protein. And then you go for twice weekly platelet count, liver enzymes, creatinine. Okay, so growth scan is to be done every 3 weekly, and the level of the Doppler is to be done every weekly, and the non-stress test has to be performed twice weekly. Okay, if at all anytime during such kind of monitoring, if any of these are found to be abnormal, this means the patient is going to be unstable. Okay, so that means you have to go for the further termination of the pregnancy by either depending upon the condition of the cervix. Okay, if all these is going to be stable, you can go for continuing the expectant management up to 37 weeks of the gestation. Okay, one more thing, in case if the fetal age is going to be just less than 34 weeks of gestation, you have to give the betnazole coverage, because anytime premature delivery may be required, and for that we need to have good fetal lungs. So that was about the mild preeclampsia, wherein what we are going is the depending upon gestational age of the fetus. If it is going to be 37 weeks, we are going to straight away terminate. If it is less than 37 weeks, we are going to go for initial assessment of all the high risk conditions of the complications which can develop in case of preeclampsia. If at all they are deranged, straight away go for termination. If not deranged, we go for again assessing in detail of every of the parameters of the blood pressure of the patient, as well as proteinuria, weight gain, and go for the fetal monitoring. If all these are found to be normal, we can go for weekly assessment and continue at 37 weeks. If any of these parameters are abnormal, just go for straight away termination, again while the stabilizing the mother. Okay, so that was about the management of a mild preeclampsia. And for that, you have another one important parameter, which is the BP controlling. So BP controlling is done with the antihypertensive drugs. We have 4 options for controlling the blood pressure in such patients. So first one here we have is the methyl dopa. Okay, so this is a drug which is going to go and act centrally, and it is given in the dose of 250 milligrams 3 times a day, where maximally it can be given up to 2 grams per day in the dose. The most one of the major side effect which is seen is the dry mouth with this drug, as well as it can lead to increased sleep or somnolence, as well as postural hypotension. And one more thing it produces is the direct Coombs test is going to be positive in such condition. Okay, so it will be producing the indirect Coombs test is going to be positive with the methyl dopa. The other drug which is most commonly used, or the first line therapy, is going to be labetalol, which is going to be the alpha and beta blocker. Okay, so alpha and beta blocker agent. We start with a dose of 100 milligrams twice daily, and it can be given to as high as 2400 milligrams per day. If any signs of the liver dysfunction take place, or asthma, or there is congestive cardiac failure, then this drug has to be discontinued. Otherwise, it is one of the safe most drug in case of the pregnancy for the controlling the blood pressure. The next drug here we have is the nifedipine. So it is a kind of the calcium channel blocker, a kind of the dihydropyridine. It is going to cause the smooth muscle relaxation, and ultimately going to cause the vasodilatation. Okay, it is given in the dose of 10 to 30 milligrams per oral, which is given thrice a day, and it can even be given in the form of the sustained release preparation, which are available for 10 to 20 milligram twice a day. Maximum is going to be given to 90 to 120 milligram per day. This can cause headache because it is going to cause vasodilatation. It can cause the headache, as well as it can cause edema, and it may sometimes lead to the allergic hepatitis, for which it can be discontinued. Lastly, you have atenolol. This is not a safer drug. You have it is going to be a beta 1 blocker. The dose is going to be 50 to 100 per oral twice a day, or OD. But the risk here is that it is going to cause the fetal growth restriction, as well as if the signs of the, since it is a beta 1 blocker, if the signs of the hypoglycemia take place in mother, it is going to mask the signs of acute hypoglycemia. So this was all about the anti-hypertensive drugs which are given to the patient if the BP is not controlled, or if it is in the range of higher than the target BP should be 136 by 86 mmHg. Now, how you're going to manage a patient with severe preeclampsia with the severe features, okay? So that was about preeclampsia, where you have the BP which is going to be raised more than 140 by 90 mmHg. Then your next step is you go for proteinuria. But along with that, you have the raised or the severe features, wherein proteinuria quantity is increasing, or there is liver is getting affected, okay, or the kidneys are getting affected, or eyes are getting affected, or brain is getting affected, or the lastly you have the lungs which is getting affected. So all these conditions are including the severe features. So what happens is, here again, what are the severe features? So is the development of the maternal pulmonary edema or the acute respiratory distress, or there is any kind of retinal injury which is seen, renal failure or stroke or myocardial infarction, okay? Or in the fetus you have abnormal fetal testing, which is the CTG, abnormal NST, or the DFMC is decreased, Liker would be decreased, or the umbilical artery, whether there is a reversal or the absent end-diastolic flow, or the fetal death takes place, or the IUGR, that is intrauterine growth restriction, is taking place. Okay, so these are going to be the severe features. Now, how you're going to manage such a case? So there is no need to continue the pregnancy beyond 34 weeks of gestation. You should remember that in case of the preeclampsia with the mild features or with no severe features, we are allowing the pregnancy to continue till 37 weeks. But in such a condition, like, there is no need to complicate the mother's life, putting the fetus at priority. So never complicate. Just if it is crossing, the fetus has crossed 34 weeks of gestation, straight away go for termination of the pregnancy. Okay, so if it is going to be less than 24 weeks of gestation, again there is no point in continuing the pregnancy, because as the gestation age increases, the mother is going to get worsened, the preeclampsia worsens, and therefore if the gestation age is going to be less than 24 weeks of gestation, you have to stabilize mother, control the BP, and prevent the seizures, and just go for the termination by induction of the labor. Okay. The question here is between, if the gestation age is between 24 weeks of gestation to 34 weeks of gestation. Okay. So in such condition, first of all, I will be talking about, as I already talked about, 34 weeks of gestation. If the fetus has crossed that, you have to again go for delivery, as well as stabilize the mother and prevent the seizures. So that is in the case if it is less than 24 weeks, or if it is more than 34 weeks. Now the question here is between those two stages. So what you're going to do is, here you have to again admit the patient in the high intensity unit or the ARBS ICU. Okay. The other thing you need to do is you have to stabilize both the mother as well as the fetus. Okay. So stabilization of the mother is the first step you need to do. Once that is done, so stabilization means what? That you have to control BP, you have to ask if any other problems are done, then are detected, then you have to maintain that. Once that is done, what you need to do is you have to go for the initial assessment. So once the mother is stabilized, in the systemic way, you are going to go for detecting each and every organ in such patient. Okay. So in case of the mother, you start with asking her for any kind of signs of imminent eclampsia are seen in her or not. Okay. Apart from that, you systematically assess the level of the lungs, you assess the heart, you go for the ECG of such a patient. Then you go for assessing the liver function test, where you're going to go for the measuring the level of the ALT, AST, as well as the LDH. You also go for, so these were the severe symptoms where you're going to ask for all these. Is she experiencing any kind of headache, vomiting, or blurring of vision, or epigastric pain? Okay. Apart from that, the CBC is to be sent, and peripheral smear is to be done. You check for low platelet counts or hemoconcentration, or there is evidence of the hemolysis, that is schistocytes are seen or not, or there is raised LDH. Okay. Then you also go for measuring the level of the creatinine, that is the renal function test is to be assessed. So once that is done, you also go for the fundal assessment of the patient. Okay, so once that is done, you go for assessing the fetus. So in fetus, you need to go for assessing the fetal growth, you need to assess the Likert value, you need to go for doing the non-stress test, and lastly you go for the umbilical artery Doppler. Okay, so if any of the abnormalities are detected on such initial evaluation, okay, so if initial evaluation abnormalities are detected, straight away go for termination. If these are present, straight away go for termination. Simultaneously you have to give the Caesar prophylaxis as well as control the blood pressure. And if the gestation, since the gestational age is going to be less than 34 weeks of gestation, you have to give betamethasone to such a patient, and the aim is to deliver in 48 to 72 hours. Okay, so that is about once the initial assessment is done. Now on initial assessment, you are finding that okay, these things are not present. Okay, then you have to hospitalize this patient and go for monitoring such a condition. Okay, so during monitoring, what you are going to see is you have to monitor the mother and simultaneously monitor the fetus. Okay, so for monitoring of the mother, you go for the daily measuring her weight, you go for daily measuring her input and output, because this is going to be an indirect way of measuring the edema which is worsening. Ask her for any kind of edema which she is developing, then regular blood pressure monitoring and antihypertensive agents as per the blood pressure. Also for the fetal maturity, you have to give the betamethasone. Okay, and every alternate day you have to send the blood investigations like the CBC for checking the level of the, again, the platelets. You have to go for LDH, you have to go for the liver function test, SGOT, SGPT, as well as serum creatinine and the electrolytes. Okay, lastly you have to go for the 24 hours urinary protein along with the dipstick protein. Okay, so that was about the mother. About the fetus, what you need to go for is daily DFMC monitoring. Along with that, you have to go for daily NST non-stress test is to be done daily. Then you have to go for the fetal Likert, which has to be done twice a week, as well as amniotic fluid, which is done twice a week, and the growth scan has to be done again twice a week. And you have to go for the Doppler studies. Okay, so Doppler studies can be done every weekly. Now, if in such condition, if the patient is going to be stable, then you can continue the monitoring in such a case and expectant management. If the patient is going to be unstable, straight away go for the, at any time if you find that okay, there is worsening of the patient or worsening of the fetus, straight away go for the termination with the seizure prevention and the control of the blood pressure. So during doing this, you have to keep in mind that one thing, that never go for the prolongation of the pregnancy in the view of the attaining the fetal maturity. So just to improve the perinatal outcomes, do not put the risk of the mother's life at risk. Okay, rather just focus on improving the maternal outcomes. Automatically, if the fetus is going to be good, will improve the fetal outcomes. Next, important thing you need to consider is that if there is sudden increase in the BP, in such a case, there is already the change in the curves of the flow as well as pressure in to various organs like the brain as well as the kidney as well as the heart has been taking place in such cases. So what happens is there is a rightward shift of these curves of the pressure flow is taking place in the cerebral, that is the brain, coronary artery, as well as the placental pressure flow, which is taking place because of the process called as autoregulation. So what happens is, if you are going to trying to cause sudden decrease in the blood pressure, okay, so sudden fall in the blood pressure takes place. Because of that, there is vasodilatation taking place, and what happens is the flow to the organ, so BP is going to decrease. BP decreases in such cases. What happens is the sudden decrease in the flow takes place. Okay, so sudden flow also decreases. This will cause the compromise to the blood flow to these vital organs, and as a result, you have to go for gradual decrease in the blood pressure rather than going for the abrupt decrease in the blood pressure in such cases. Okay, next is about the diuretics. You need to keep in mind that diuretics are not supposed to be given during the antenatal period, because what happens is, if there is already baby inside the mother and if you're giving diuretics, diuretics, there is sudden decrease in the intravascular volume which is taking place. Now what happens is this intravascular volume decrease will also cause the decreased blood supply to the fetus, and ultimately it predisposes to the fetal growth restriction. Rather, once the delivery of the baby takes place, in order to prevent the development of pulmonary edema, you can give the diuretics in for the prophylaxis to the acute pulmonary edema. So you can also give Lasix following the delivery of the baby. The only indication of the diuretics in a case of the antenatal patient would be the development of pulmonary edema, unless and until you are not supposed to give the furosemide to the patient who is having pregnancy. Okay. Next you have is the imminent or the impending eclampsia or the acute fulminant eclampsia. So here, what does this mean? It is the sudden worsening of the condition. Who is a known case of diagnosed preeclampsia? There is sudden worsening of the condition, and so consider a patient who was diagnosed having preeclampsia. She is on a maintained condition. You decide her to go for the expected management, and then on regular basis she is coming for the evaluation and monitoring, and you find everything is normal. But one fine day she comes with the complaint to the emergency. Okay, that yes, I'm experiencing some kind of the headache since morning, or vomiting. There were 3-4 episodes of vomiting which were projectile, or there is sudden level development of epigastric pain, or that she experienced blurring of vision, and all these. So all these implies what? That there is sudden worsening of the already existing preeclampsia which has taken place. So this is here. Patient complains of following symptoms. I already mentioned about them. That is severe headache or restlessness or vomiting, epigastric pain or blurring of the vision which is taking place. So how we are going to manage such a case? So management of such a case depends, because all these are associated with a very high blood pressure that is going to be called as the acute hypertensive emergency. Okay, it is called as the hypertensive emergency. So for managing such a condition, what you're going to do is, the aim is to normalize BP, okay, prevent seizures, okay, by giving the Maxilf prophylaxis, and you have to go for the delivery, that is the termination of pregnancy. So for controlling the BP, you have various intravenous agents which are used, which includes the intravenous labetalol as well as hydralazine, and you can also go for giving nifedipine, which can be given orally. Okay. Magnesium sulfate can be given in the full loading dose, can be given to the patient. If you are going for the either the Zuspan regimen or the Pitchard's regimen, the maintenance dose can be avoided, but loading dose can be given. This will help in preventing the seizures, which is going to be one of the complication of such kind of the hypertensive emergencies or the imminent eclampsia. And lastly, we all know that the placenta is going to be the pathology behind the development of such condition. So you just have to remove the placenta. So the urgent immediate termination is advised. Okay. So for control of BP, what you have various options are there. So first is the intravenous labetalol. Okay. Mind well that in case of the preeclampsia, for the daily monitoring, we are giving the oral agent rather than the intravenous. So we give the IV labetalol is given 20 milligrams slowly over 2 minutes. Okay. After that is given, you repeat the blood pressure monitoring after 10 minutes, even if the BP is not controlled. If the values are going to be more than 160 systolic and more than 110 diastolic, you can repeat the labetalol with increasing the dose of 40 milligrams. Okay, again take the blood pressure after 10 minutes, again give it 80 milligrams. If needed, you can again give the 80 milligrams. Now the maximum dose of labetalol is, if it is given intravenously in one session, is going to be 220 milligrams. Okay, so understand this is going to be the maximum dose which is given intravenously, whereas if it is given orally, the maximum dose was 2400 milligrams. Okay, so understand these two doses. Now still the BP is not controlled, then after 10 minutes you are taking, you have to switch it over to hydralazine, which is given 10 milligrams over 2 minutes. Okay, after giving hydralazine, it is going to take a bit longer to have its effect. You are going to measure BP after 20 minutes. Okay, if not still controlled, you can call for the anesthetist reassessment as well as the evaluation by the physician, as well as the other drugs can be given. Okay, and once the BP is controlled, the threshold has been achieved, to go for regular monitoring of BP. For the first hour, that is done every 10 minutes. Later on, in the second hour, it is to be done every 15 minutes. In the third hour, it is to be done every 30 minutes. And then it has to be monitored every 4 hourly. So that was about you using the labetalol as well as hydralazine. Okay. The other option you have is the nifedipine. Here you need to understand there is no intravenous preparation for nifedipine which is available. It is only oral nifedipine which is given in the 10 milligrams. Again, after 20 minutes, you are going to take the blood pressure. If it is still not controlled, you can give the repeat dose, increasing the dose of nifedipine of 20 milligrams. Again, after 20 minutes, you can again repeat the 20 milligrams of the nifedipine. Still, if it is not controlled, then again switch over to the labetalol, which is given in the dose of 40 milligrams. Okay, so that was about the hypertensive emergency. So this in the part one of the hypertensive disorders of the pregnancy, we talked about what are the broad classification. We talked about the gestational hypertension, which has two varieties. One is going to be the mild and other one is going to be severe. Next, we talked about what was the pathogenesis and the etiological factors which are causing the risk of development of the preeclampsia, which is one kind of a systemic inflammatory condition. And next we talk about the what are the different organs which are affected and the pathology which is there seen in such condition. And next class we talked about how you are going to manage a case of preeclampsia. Either it is going to be a mild or preeclampsia with the severe features. Okay, so there are two broad classification, that is the preeclampsia without severe features and preeclampsia with the severe features. So that was about in today's section in the part one. In the next hypertensive disorders of the pregnancy part 2, we will be discussing about the various other complications like the eclampsia as well as the chronic hypertension. I hope you students understood. Thank you so much.